Hello guys, welcome to part 6 of our unit on GI surgery. Before I move on with the lecture, I'd like to add a disclaimer that I do not own any of the pictures or illustrations I've used in this video. Now we're going to be talking about Achalasia Cardia. Simply put, Achalasia Cardia is the complete opposite of GERD. In GERD, we had an incompetent LES where it wasn't as tight as it's supposed to be, which resulted in reflux and associated complications. But over here, we end up with a lower esophageal sphincter, which is extremely tight and is not loosening and not allowing the food bolus to pass through. Achalasia is the Greco-English word to relax or loosen. And cardia is the part of the stomach after the ileus. So Achalasia Cardia can be defined as a mobility disorder characterized by failure of relaxation of the lower esophageal sphincter. Now let's talk about pathology. We know that the esophagus is innervated by only the Auerbach's plexus, unlike the stomach, which is innervated by both Auerbach's and Meissner's plexus. Now the Auerbach's plexus has two sets of neurons. One is the stimulatory neuron, which causes closure of the lower esophageal sphincter, and the other is the inhibitory neuron, which causes relaxation of the lower esophageal sphincter. So this is the stimulatory and this is the inhibitory. What happens in Achalasia Cardia is that we have selective loss of the inhibitory neurons of the Auerbach's plexus. Now the cause of this is mostly not known, so we consider it to be idiopathic. But in some instances, such as Chagas disease, we can see selective loss of these neurons also in malignancies. Achalasia Cardia is classified into primary and secondary. Secondary is also known as pseudoachalasia. Primary is when the Achalasia Cardia's cause is not known, that is, it's idiopathic. Secondary Achalasia Cardia is when we know the cause. For example, in case of Chagas disease and malignancies. Clinical features. Now, due to a really tightly closed lower esophageal sphincter, there's actually accumulation of food and water in the esophagus, which can end up rotting and result in bad smell. Along with that, there can also be difficulty in swallowing, which results in dysphagia. And due to dysphagia, we might not be able to eat well, and that could result in weight loss. And there's also a risk of regurgitation. Investigations. We can get a differential with the help of a barium swallow. We can see a bird's beak appearance in the barium swallow as depicted in this X-ray right here. We can confirm the diagnosis with the help of a manometry. Since this is the first time I've mentioned it, let's talk about it. What a manometry is that the physician uses a tube like a catheter tube, which has certain pressure sensors within it at a set amount of distance from each other. He then puts this tube within your esophagus, and then he ends up with a graph from the reading from these pressure sensors. So what he does is he puts this tube in your esophagus, and then he makes you swallow a series of substances of various consistencies, and then the response from these sensors is recorded in a graph. So the graph looks somewhat like this, where at rest there would only be straight lines. from the sensors. Each line depicts a single sensor at one particular level of the esophagus. And if there was some contraction or anything happening, there would be a response like this on this graph. In case of Achalasia Cardia, what happens is, even without giving the patient anything to swallow, the upper esophagus is normal. We can see straight lines at rest. But at the lower esophageal sphincters level, we can see a sustained contraction. And this is happening even without giving anything to swallow to the patient. So this is how you can confirm the diagnosis of Achalasia Cardia using manometry. Along with this, it's also necessary to do regular endoscopy and biopsy to rule out cancer. Now let's talk about management. Medically, we tend to give smooth muscle relaxants such as calcium channel blockers and nitrates. And then Botox injections. And we also try to dilate the LES directly with the help of balloons or bogies. The surgery of choice for this condition is a Heller's cardiomyotomy with the laparoscopic approach. Let's talk about the surgery now. Suppose this is the abdomen. What we do is we take 5 incisions, 1, 2, 3, 4, and 5. And through these incisions, we insert the laparoscopic camera and port. And then we reach the esophagus. And then on the esophagus, we create the myotomy. Now, after the myotomy, this could result in a reflux, even though we have fixed the original problem of a really tight LES. Now there's a risk of reflux. So what we do is we follow this surgery up with a partial fundoplication. And that's all you need to know about Heller's cardiomyotomy. What I would like you guys to additionally remember is these days we use a newer procedure known as POEM, that is per oral endoscopic myotomy, where we use an endoscope to perform the same myotomy orally. We just need to know the name, no need of knowing the procedure over there. Now, complications, as I previously discussed, that there is accumulation of food and water. So this also poses a risk of aspiration. And due to aspiration, we could end up with pneumonitis, which could also result in a lung abscess. And in case of Achalasia Cardia, there is also an increased risk for a squamous cell carcinoma. And that concludes this lecture. Thank you for watching.